Welcome back, our fans. Neuromuscular disorders. Bell's palsy, facial nerve palsy, one of the most common causes of unilateral facial weakness. Facial nerve, seventh cranial nerve, gives normal nerve supply, motor supply to muscles of facial expression. Forehead around the eye, around the mouth, cheeks. Nerve to stapedius, muscle in the ear. Parasympathetic fibers to lacrimal and salivary glands. Chorda tympani for taste, sensation of the anterior 2/3 of the tongue. General sensation to the outer ear and oropharynx. In Bell's palsy, no wrinkling to the forehead when raising the eyebrows. Unable to close the eye tightly, unable to blow the cheeks or whistle. Unable to smile widely, dropped corner of the mouth. Unilateral diminished salivation and tear secretion, eye dryness. No loss of taste associated. Vesicles in the ear or on the palate. May indicate herpes zoster infection. Ramsay Hunt. Symptoms develop over a few hours, with pain around the ear preceding the unilateral facial weakness. Treatment. Middle. Corticosteroid, if used within 3 days after the onset, improves the chances of complete recovery. Middle. Physiotherapy. 1. Cerebrovascular disease. Middle. Disorders of the cerebral blood vessels that cause impaired cerebral circulation. Middle. Stroke, also called cerebrovascular accident, refers to the sudden impairment in blood flow to the brain resulting in cell injury and death. Middle. It manifests as loss of neurologic function, including loss of motor, sensory, visual, and cognitive function. Dental management of a patient having history of stroke. 1. Stroke patients may have physical disabilities. They may have reduced swallowing and gag reflex, causing dysphagia. Impaired masticatory muscle tone reduces food clearance. In addition, poor motor control of hands results in inefficient oral hygiene. Also, high risk of caries and periodontal disease. 2. Patients are on antiplatelet and anticoagulant therapy, so increased bleeding tendency is expected. Middle. Lab investigations, INR must be less than 3.5 times the normal before routine treatment or minor dental surgery. Middle. Drugs should not be discontinued before dental treatment due to thromboembolic risk. Middle. Bleeding should be managed by local hemostatic measures. Middle. NSAIDs should be avoided as they increase the risk of bleeding. 3. Stress reduction protocol is that used with hypertensive patients. 4. Whenever the patient is able to withstand the dental procedure, it should be performed after physician's consultation. No evidence supporting the need to postpone treatment for 6 months following the accident. 3. Parkinsonism, Parkinson's disease. A progressive neurodegenerative disorder leading to tremors, muscle rigidity and slowness of movement, short shuffling gait. Oral manifestations. 1. Gag reflex impairment, risk of aspiration. 2. Poor swallowing reflex causing dysphagia. 3. Impaired chewing and slow speech. 4. Involuntary lip and or tongue movement. 5. Medication-induced reactions/side effects. A. Xerostomia, increased risk of caries and periodontal disease. B. Blood cell abnormalities, reduction in count of RBCs, WBCs or platelets. Dental management of a patient having Parkinson's disease. 1. Anxiety in a Parkinson's disease patient can increase both the tremor and the degree of muscle rigidity. Pretreatment sedation is often recommended. 2. Difficulty maintaining their oral hygiene, thus more frequent recall may be necessary. 3. Due to muscle stiffness, mouth props and rubber dams are better used. 4. Due to dysphagia and an altered gag reflex, patient must be treated in an upright position to avoid the aspiration of water or materials used during dental procedures. 5. Drugs may interact with epinephrine, prolonging its vasoconstrictor effect, so, a maximum dose of 2 carpules of epinephrine containing local anesthesia is allowed. 6. Regular CBC to detect drug-related hematologic adverse effects. 4. Epilepsy. Middle. Epilepsy indicates a chronic manifestation of brain damage that results in abnormal electrical brain activity and electrical discharges. Middle. They are usually self-limiting. Types include A. Tonic-clonic generalized seizure, historically, grand mal epilepsy. O lasts less than 3 minutes. O. Forceful involuntary contractions of voluntary muscles. I. Aura, hallucinations, changes in mood or behavior, disorientation, slurring of speech and blinking, loss of consciousness. 2. Tonic phase, the entire musculature contracting forcibly, spasm. Middle. Contraction of the muscles of the larynx and forced expiration can produce a loud moan, often termed an epileptic cry. Patients often become cyanotic. Middle. Danger of injury, biting of tongue and lips. Middle. Lasts for less than 1 minute. 3. Clonic phase, the entire body rhythmically jerks for no longer than 1 minute. 4. Postictal phase, the patient may be unresponsive for 10 to 15 minutes, awakening gradually, often with no memory of the event, followed by long sleep. B. Absence seizures, historically called petit mal epilepsy. Middle. Seconds of sudden loss of awareness or conscious activity with no loss of body tone. Middle. No postictal confusion in patients experiencing absence seizures. Middle. Recurs many times. Status epilepticus. Middle. A seizure lasting for more than 30 minutes, or repeated seizures over the same period without intervening periods of consciousness. Middle. Serious sequelae of this condition, including bodily injury, cardiorespiratory dysfunction, irreversible neurologic damage, death may result. Oral manifestations of epilepsy. 1. 2. Ride convulsions, frequent dental, oral and facial traumatic injuries. 2. Side effects of anticonvulsants. A. Phenytoin, gingival hyperplasia and systemic lupus erythematosus like oral ulcers. B. Carbamazepine, bone marrow depression, increased infection. C. Valproic acid, antiplatelet function, palatal peachy. D. Xerostomia, stomatitis and glossitis. Dental management of an epileptic patient. 1. Timing, appointment at time of least frequent attacks, known from history. 2. Patients should cancel the appointment if they feel that their seizures are poorly controlled on the day. 3. Patients with poorly or uncontrolled seizure disorder should be referred to a hospital setting for routine dental care. 4. Avoid any known triggers of the patient's seizure activity, known from history, withdrawal of anticonvulsant medication, epileptogenic drugs. Fatigue, starvation, stress, infection, flickering lights. 5. Conscious sedation using midazolam. 6. Use of dental floss secured mouth props, which are easily retrievable, and a rubber dam is recommended. 1. Placement of metal fixed prostheses is recommended rather than removable prostheses to decrease the risk of displacement and aspiration during seizure activity. 2. Routine complete blood picture before dental treatment to evaluate drug-induced blood dyscrasias. 3. For gingival hyperplasia. Middle. Frequent periodontal treatment. Middle. Chlorhexidine mouthwash. Middle. Gingivectomy or gingivoplasty when indicated. 4. Some drugs interact with anticonvulsants, causing the normal dose of anticonvulsants act as an overdose, reduce their metabolism. Aspirin and NSAIDs, azole antifungals, erythromycin and metronidazole. Seizures in the dental clinic. 1. Stop the procedure and remove anything in the patient's mouth. 2. Ask for help from colleagues in the clinic. 3. The patient is laid supine in the chair. 4. Protect the patient from injury by passive restraint and removing any surrounding equipment. 5. Gently extend the neck backwards to maintain the airway if the patient became cyanotic. 6. In an uncomplicated seizure, no other treatment is needed. 7. If the fit continues for longer than normal, or greater than 10 minutes, midazolam 10 mg IM should be given. 8. If the fit does not resolve within the next 5 minutes, status epilepticus may develop. Middle. Ambulance should be called. Middle. While waiting, the airway should be protected, with suction to remove excess saliva, and high-flow oxygen administered. Thanks for watching. Support us by likes and subscribes.